The one thing that's clear from all of these diseases is that they all affect the epithelial cells in the body, these cells that line the airways. And this is a cartoon representation on the left-hand side of what these epithelial cells look like. And as you move from the bottom of that cartoon that represents the alveoli or the air sacs of the lung, and you move upward, you move into the airway. And these arrows that are on there represent the movement of mucus and trapped particles out of the lung. And so if this works normally, it looks exactly like the video on the right-hand side there. This is from taking a device that kind of looks like a plastic toothpick, and gently, some of my patients may say not so gently, but gently scraping the inside of the nose to allow us to obtain these cells. We can then put them under a high-speed phase contrast video microscope and measure the characteristics of the beating of these cilia to look for differences that might be seen and to begin exploring these cells to look for what are called host defense problems that might predispose to acquiring mycobacterial infections. And so, whereas most of the time in my lab to try to understand, or our lab, why somebody gets mycobacteria, my boss, Steve Holland, draws blood from a patient. They go and they isolate the white blood cells and they study those. They figure out what the defect is and try to correct what's going on in the blood. What we need to do is to study cells in the lung to try to find the same thing, because it's quite clear that this disease is focused in the lung and it doesn't affect bloodstream-related problems. So this is our experimental design, and many of you in this room are relatively familiar with this, but we can do two things. We can sample airway cells by going down into the lung, a procedure called bronchoscopy, which is time-consuming. It's not so pleasant to have done. It's not something we can incorporate into a clinic visit. Or we can obtain airway lining cells from the top of the airway, which begins in the nose and the sinuses. And so this takes about 5 minutes to do. It can be incorporated into a clinic visit, and we can obtain a fairly large number of cells by doing this. We can either put them into solution and grow them up in a dish, they become flattened. They don't look like the cells in the airway. If we treat them by exposing the top surface to air and the bottom surface to nutrients like they have in the body, over a period of weeks, they begin to look just like they did in the body. So they go from being flat to standing upright, they grow cilia again, they grow mucus-producing cells, and we can generate a layer of cells that look just like they did when they were in the body. And this allows us to do studies in the lab to try to understand why they may be more susceptible. So there's a number of things we can focus on when we have these cells. We can look at things like cytokine production, these reactive chemicals to being irritated in the body. We can look at expressions in genes. We can look at mucus production, which might affect the ability to clear things out of the lung. And we can look at things like ciliary beat frequency to try to understand this better. We've also found that we can skip this about 6-week process of going from the nose to an experimental model by taking the cells right out of the nose and bringing them into the lab. And we know that we have about 48 hours to work with those cells. They retain exactly the same properties as when we grow them up in primary culture, and this has greatly facilitated our ability to do this research. It just requires whoever's doing the research to spend many hours in the lab once we've seen you in the clinic. So a lot of these are done between 3 and 4 in the morning. One of the things that we found, and this has been very consistent among the patients that we've studied with pulmonary NTM disease, is if we measured the frequency of the beating of these cilia, these little hair-like structures on the surface of the airway, it's consistently very different from normal controls. And when we age and gender-matched controls and we obtain samples from them in the same way and we do the same analyses on them, they have a ciliary beat frequency that's very consistent. If we compare that to cystic fibrosis, which is one of the susceptible conditions associated with this, many of the CF patients have ciliary beat frequency in the normal range. If we look at it in this genetic condition associated with abnormal cilia movement, this primary ciliary dyskinesia, those patients have a more exaggerated abnormality in the beating of these cilia. But the NTM patients are sort of midway in between normal and the exaggerated abnormalities we see with the full-blown genetic syndrome of abnormal cilia movement. And so this is interesting in and of itself, but it's given us a biological tool that we can then use to probe certain innate defense mechanisms in these cells to look at things that might predispose to mycobacteria. So this work will actually be presented by a graduate student who's worked with us over the last several years, who's just successfully defended his dissertation at Cambridge based on this work, and will be going back to medical school at Tufts. Unfortunate for us, but fortunately for the medical community as he pursues his medical studies. But the exciting part about this work is that it looks like it's directly, or maybe directly associated with treatments that might be effective. And this is from similar work that's going on in the lab, looking at ways of trying to reverse this abnormality and slowing of the beating of the cilia. And NO stands for not the word no, but the gas nitric oxide. And nitric oxide is an interesting gas for a number of reasons. It's responsible for more and more bodily associated functions as we begin to learn more and more about it, but it is produced on the airway surface. And if we look at what happens when we apply what's called a nitric oxide donor to these cells, if you look over on the left-hand side, if we increase the amount of nitric oxide that these cells are seeing, nothing happens. We know there's an association between the beat of cilia and nitric oxide, because when the cilia don't move at all, the production of nitric oxide on the airway surface goes way down. But in the normal state, that signal doesn't play a role in keeping the cilia beating normally. If you take patients with pulmonary NTM on the right-hand side of that graph, if you look at baseline, the frequency of their cilia beat, as you see on the y-axis there in hertz, is lower than what you see in normals. But when you augment their nitric oxide, you restore that ciliary beat frequency back up to normal. And the reason that may be important, and again, this needs to be studied, is that there are available drugs that do exactly what we've done in the lab. They're designed to increase the availability of either nitric oxide, or they affect by signaling downstream from where nitric oxide works to make these cells have cilia that beat more normally. And some of those classes of drugs are used to treat diseases that appear on television an awful lot, things like pulmonary hypertension, which we talked about, or erectile dysfunction from drugs like sildenafil or Viagra. The other very interesting thing about this general pathway that ends up in augmenting the beating of these cilia is that one arm of that can be affected by hormones like estrogen. And it may be that we could apply estrogen to the cells and see the very similar type effect. So as was alluded to earlier, this opens up sort of an armamentarium of available drugs that might get at this basic defect of the disease. So when you talk about new drug options for NTM, the general pattern of what's available right now are drugs that target the underlying bronchiectasis. These are borrowed mainly from drug development in cystic fibrosis, and most of these are aimed either at improving airway clearance or reducing airway inflammation, or drugs that target the NTM infection. And again, a lot of this is borrowed from drug development, either in cystic fibrosis, where these are anti-infectives that target Pseudomonas predominantly, but also cover mycobacteria, or borrowed from drug development in tuberculosis. And one of the reasons I was very interested in coming to the lab where I work at NIH is that one of the branches of that lab is a drug development lab for tuberculosis. And our hope is that if I hang out around those folks long enough, they'll sort of throw me some of the crumbs of what's being developed for TB, drugs that might be effective against NTM as well. Unfortunately, I think it's going to be a very uphill battle and probably a very prolonged process to think about drug development specifically for NTM. So I think this borrowing effect is really where we need to look. And just to talk about a bit about what's available now in terms of drugs that are being studied for this, we're now at a very exciting point of time. We're about 3/4 of the way through enrollment into the first multi-site trial targeting NTM lung disease specifically, and it's with a drug called Arikace, which takes a concept of repackaging or reformulating old drugs that are known to be effective against mycobacteria but highly toxic, and putting them in a way to where you can concentrate the drug in the area of greatest need, you can mask it from areas where toxicity may be associated, and hopefully get a greater killing effect against the mycobacteria relative to the toxicity in the human that's taking the drug. So this trial is now targeting treatment refractory patients who have either M. avium complex or M. abscessus. These are patients that have been on a guidelines-based therapeutic regimen and are still culture positive, and looking to see if we add this drug on, whether we can have a greater effect of getting the disease under control. And this, again, the general design of this drug is to sort of hide it in the middle of what are called liposomes or fat droplets, to where when the body's organs like the ears or the kidneys see the drug, instead of seeing active drug, they see fat particles which don't have the same associated toxicity. It's also generated in a particle size that targets the area of the lung where disease is most notable. So this is a general overall design of this trial. I won't go into it in a lot of detail, but basically we're looking for people who are not responding to their current treatment. They get randomized during the first basically 3 months of this trial into either active drug or placebo. At the end of that time, everyone has the option of going into a 3-month open label phase of the study where everyone gets active drug, and then they're followed a month after completion of the drug. So in terms of looking at things, one of the things that Philip asked us to do was to try to look at potential roadblocks of getting to where we want to be. And if you look at the drug development roadblocks for this disease, one of the glaring things that we're missing is an accurate animal model of the disease. When you give mice, for example, mycobacteria, either by injecting it or having them inhale it, they don't generally get disease that mimics what we see in humans. This very airway-centric related disease that becomes very inflamed around the airways and relatively spares the air exchange parts of the lung. They get a mycobacterial pneumonia, which is a very different sort of treatment type thing, and it's hard to draw correlations with different drugs. Most mice actually clear mycobacteria fairly rapidly as well. So I think we need to focus on developing current models that are adequate for safety assessment of these drugs. We need to find models that are adequate for evaluating efficacy of the drug, and to find models that mimic human disease. And I think there's some progress being made on this front by researchers at the University of Colorado and potentially at the University of North Carolina as well. And then I think another thing that is missing but we're making headway on is lacking the infrastructure to support clinical trials. We found this out in the current study where it's somewhat difficult to find out where groups of these patients are, especially if you're looking at only a fraction of the patients, and be able to generate the organization that it takes to get people interested in and participating in clinical trials so that we can evaluate these drugs. The gold standard for doing this is the model that's been set up by the Cystic Fibrosis Foundation, where they have a very organized system of clinical care centers where patients are very easily identified for participation in clinical trials. They have a whole network that's available to assist the pharmaceutical industry in getting those drugs into trials and to support and monitor those trials. And I think that the efforts that are being done by Philip in association with colleagues in NTM-IR are going a long way at doing things like improving communication between patients, and patients are going to their physicians and saying, hey, what about clinical trials? Is there anything available that I might qualify for? It's organizing physicians to pay more attention to this disease and to think about looking for clinical trials to put patients in. And I think one of the most important things is coupling this disease with a national registry movement for bronchiectasis in general, which is very much targeting the pharmaceutical industry and trying to pull drugs that are being developed for other purposes into the treatment of non-cystic fibrosis bronchiectasis and hopefully for the treatment of mycobacterial infections as well. So just in summary, who gets this? It's clear that the prevalence increases as age increases, especially after the 5th decade. The relative prevalence in women to men increases with age. Bronchiectasis is the most associated comorbid condition with these infections. There are likely environmental and potentially genetic determinants. Knowledge of the basic defect, I'm very hopeful, will lead to specific treatment, but we need improved preclinical models, animal models, an enhanced patient network to facilitate drug trials. It's been an honor and a privilege to be able to speak to you today, and I thank the organizers once again for the invitation.